Good evening, everyone. It's great to have everybody log in for this very interesting webinar, Tracheo Oesophageal Fistula, all about it. So I'm Dr. Pratibha Singhal from Mumbai. I'm going to just give a very quick overview, and then we're going to have an esteemed group of panelists who I will introduce. So Tracheo Oesophageal Fistula is basically a pathological connection between the trachea and the esophagus that is associated with various underlying conditions, primarily malignancies, infections, inhalational injuries, and traumatic damage. So traumatic could be either sometimes prolonged intubation, tracheostomy, or some road traffic accidents. So different types are congenital, which are mainly associated with esophageal atresia. Sometimes they can be associated in children with the vectoral complex, which has various other anomalies, including the vertebrae, cardiac defects, and renal and urinary defects. And in acquired, we have the benign and the malignant, and both approximately form about 50% of the cases of TOF that present to us. And the most common malignancy, as we all must be aware of, is esophageal carcinoma. The usual presentation could be, if it's very severe, then it's respiratory distress, or usually patients can have dysphagia and recurrent lung infections when the TOF is small. So usual prognosis, why are we talking about this, is that when it's a malignant TOF, median survival is just about 3 months. It requires a multidisciplinary involvement, which is why we have this lovely group of panelists over here. In esophageal carcinoma, it could be either due to disease progression or even due to the treatment modalities. And why does it happen is because the upper and mid esophagus is very close to the posterior tracheal wall, and therefore it is very easy to form a tracheoesophageal fistula whenever there is a break in the barrier. How do we diagnose it? To look for any features to suggest TOF, like aspiration pneumonia. We look at a contrast CT or an esophagogram, combine endoscopy and bronchoscopy. When do we do what? We are going to discuss in the panels. And sometimes when it is a poorly visualized fistula, oral administration of methylene blue before an endoscopic evaluation could help in the identification of TOF. Management, pediatric patients is something that we don't often deal with. However, just for your information, surgical repair in esophageal atresia is a primary treatment of choice. I'm sure our CVTS surgeon will, shed more light on it. And tissue adhesive, even in small pediatric TOFs, have been studied and have had success rates of 48% with the histocryl and 55% with the fibrin adhesive. As far as adults is concerned, adult TOFs have diagnostic and management challenges, both through pulmonologists, gastroenterologists, and thoracic surgeons alike. And therefore, we are having this webinar. And stents, although they have been a cornerstone in the management of TOF, but there is a large gap in our understanding of their efficacy and precise methodology. Therefore, in TOF, stenting procedure is both an art and science. And this is what we are going to discuss in great detail going forward. So with that, I would like to introduce my panelists for today. We have with us Dr. Deepak Muthreja, who is from Delhi, and he is a consultant interventional pulmonologist at the American Oncology Institute. Sorry, he's not from Delhi, he's from Nagpur. Sorry, Deepak. From the American Oncology Institute, Nagpur. Aditya Chawla, I'm sure everybody knows, he's Dr. Rakesh Chawla's son. He's an interventional pulmonologist at the Jaipur Golden Hospital, New Delhi. Then we have Dr. Viswesvaran, who does not need any introduction. However, just for those few of you who don't know him, he is an interventional pulmonologist at the Hyderabad group of hospitals at the Sonajiguda branch in Hyderabad. And lastly, but not the least, we have with us Dr. Sukhram Bishnoi, who's a consultant thoracic surgeon at the Institute of Chest Surgery, Onco and Lung Transplant at the Medanta Hospital, Gurugram. And I've recently had the pleasure of interacting with Sukhram a couple of times. And he comes across as a very unassuming, down-to-earth person, but he's great at his work. So I'm sure he's going to have a lot of inputs for us, especially because we don't have that much, sometimes I think we get too focused on just interventions and we don't know when to not do interventions and send for surgery. So with that, I'd like to start our panel discussion. Welcome, everyone.
Thank you, ma'am.
Thank you, ma'am.
So our first question is to Dr. Deepak. In clinical setting, how often do you see a patient of TOF, and what is the most common etiology?
Yeah. So as we were talking, that I recently moved to this oncology institute. So earlier I was not finding many TEF patients, but now I'm seeing at least once a week or once in 2 weeks. So the most common etiology is esophageal malignancies, and we are also seeing patients who are undergoing therapy for esophageal malignancy. Recently, we had a F secondary to the radiotherapy which was given for the esophageal malignancy. So these are now in the last 6 months, I'm having this more of patients of F secondary to the esophageal malignancies.
Okay.
Now you rightly mentioned there are further there are different causes are already there, like inhalation injury, trauma, road traffic accidents, but we are not seeing them so frequently.
Correct. Anything else, Viswesvaran, would you like to add what happens in your center? Because Deepak, now being an oncology center, is probably going to see more of them compared to what we see in routine pulmonology.
So generally, the basic classification we do is whether we are dealing with a malignancy or a non-malignant. So malignancy, as Sir said, esophageal cancer is the most common, but sometimes you can see it with even with lymphomas, you can see it with laryngeal tumors, and even for that matter, your tracheal tumors. And but the most common other reason for TEF, which we generally see, is because of prolonged intubation or an traumatic intubations when they do, or a traumatic tracheostomy which they do, or very rarely you can see it in some sort of a corrosive poisoning, like people who take corrosive poisoning as an ingestional toxicity that can cause. And so even and there are a few instances. What we should not forget is TB can also cause, because of a mediastinal node involvement. The node may rupture into both the lumens and can cause a TEF. So understanding this pathological difference is very important, because in malignancy, our point of intention is palliative. So whereas when it comes to benign, that is where the role of the surgery takes more precedence over this. So whenever we see a TEF, we classify into either malignancy or benign, because the management totally differs depending upon the etiology.
Yeah. Aditya, any inputs from you, please?
Ma'am, actually in our center also, we are not seeing much of malignant cases. We are mostly seeing those who are prolonged intubation and prolonged tracheostomies and tubercular. I had the privilege of coming across 2 cases in the last year. One was the rupture of lymph node, like Viswesvaran said. So yeah, mostly they are prolonged intubation and tracheostomies.
Correct. So we recently came across 2 cases of mucormycosis, which resulted in a tracheo esophageal fistula also. So infections is something that we should not forget in our country, especially. Great. So moving on to our next question. Aditya, if you could please take this one. Does the etiology of TOF predispose to the anatomical location of where you are seeing the fistula?
So yes, ma'am, the location does depend on the etiology and the nature of the injury. Like the cuff-related injury, it will be in the mid to the distal trachea, corresponding to the location of the cuff. Then the most traumatic TUFs are in the motor vehicle accidents, RTAs, in which the mid level of the trachea suffers, and at the level of the carina, the chest wall crush injuries where there are. And so the location of the TUFs caused by the inhalation injuries and aspiration of the toxic substances, they are less well defined. But yeah, it does depend on the etiology and the nature of the injury.
Correct. Also, sometimes, in fact, when you have esophageal malignancies, you could even have a tracheobronchial fistula, right? Because it is much lower down that can present. So that is another thing that one must keep a lookout for. So, yeah. So, Viswesvaran, this question is for you, please. In which clinical setting would you suspect the presence of a fistula?
So generally in oncology setting, especially with patients with esophageal cancer or other sort of malignancy, when they present to us with recurrent bouts of coughing or breathlessness while feeding, which we call as the Ono's sign, if it is there, then that is the most specific symptom which the patient comes with. But the other things what we have to look is any unresolving pneumonia or recurrent pneumonias. Patients presents to you with recurrent pneumonias with malignancies, especially involving the aerodigestive system like tracheal tumors or esophageal tumors, or for that matter laryngeal tumors, then you should still suspect TEF. And continuous fever is also an attributed cause in these patients. This is with respect to the malignancy, but when it comes to the most important thing is TEF can also occur in an intubated patient. So that is where we generally miss. So when, as we saw prolonged intubation and prolonged tracheostomy, so generally these patients present with leaks in the ventilator. Sometimes you will be looking for leaks everywhere, but if the leak is continuous in the ventilator, or if there is a consistent bloating of the stomach, which occurs when you are ventilating these patients, or when there can be subcutaneous emphysema because now the tract is compromised, so you can have a subcutaneous emphysema, or recurrent pneumonias in an intubated patients, then also you should suspect possibly TEF is there. Or very rarely you may see patients who are difficult to wean. You try to wean them, but they will not be able to wean them. So in such cases, you can also suspect a TEF. So any prolonged intubation or prolonged tracheostomy or a traumatic intubation or traumatic tracheostomy, in an ICU setting, you should always suspect TEF, or a recurrent pneumonia or coughing or difficulty in breathing while swallowing in a malignancy patient also we should suspect TEF.
Correct. So great elaboration. That was a very good point of ventilated patients, prolonged ventilated patients, especially now going forward that we are doing, we have patients, who are on prolonged on ECMO or we have better modalities of managing patients on ventilator. Often we miss these things. So moving forward, Deepak, what are the medical management of tracheoesophageal fistulas other than what we are going to look at the definitive management in terms of stent and surgeries?
So actually the patients normally present with recurrent pneumonias. So one has to provide them proper broad spectrum antibiotics. If they are coming up with respiratory failure, tend to correct those. And secondly, we have to maintain their nutrition as well. We cannot give them continuous oral feeding because that will lead to more of aspiration pneumonias. So either we can have a TPN or we can have a gastrostomy done for these patients. For them, this would be like gastrostomy will not come under the medical management, but yes, percutaneous endoscopic gastrostomy can be given. An option can be given for that to the patient to maintain the nutrition, other than total pancreatic nutrition.
Correct. I think other measures like feeding them in all feeds, RT feeds, or everything in the propped up position, other small measures. Is there any role of, H2 receptor as anti-reflux therapy? Any role of that? Any evidence to that? All the panelists can take this.
Presently, we didn't find any evidence for use of it, but it is always used by the gastroenterologist.
Correct. Going forward, so what are the non-invasive investigations that would clinch the diagnosis of tracheoesophageal fistula? Aditya, if you could please take this.
Ma'am, first of all, we need to get an X-ray done, which suggests the features of aspiration and the symptomatology of the patient. If the patient is complaining of recurrent infections more often, and the patient is having regurgitation of the acidic contents, then, and we get an contrast CT to be more precise that we are encountering a problem of tracheal stenosis or an esophagogram. So to confirm that everything, we need to get an endoscopy done and a bronchoscopy done to localize the TEF and then plan accordingly.
Correct. What about bronchoscopy is mandatory in all patients, Viswesvaran? What do you say? Because
definitely, ma'am. Bronchoscopy is the bronchoscopy or esophagoscopy are the modalities to confirm the presence of TEF. You may get some clues when you do the barium swallow or something, but to confirm the extension of the TEF or to confirm the location and to plan the further management, bronchoscopy and or esophagoscopy are the modalities of choice, and that should be performed in every patient. We should not just see the barium swallow and confirm it. Yes, that will give you a clue, that will also confirm to an extent, but further planning for the procedure or treatment requires an evaluation with a bronchoscopy in case of a tracheoesophageal fistula.
Okay. So what all would you look for in a bronchoscopy when you do it?
So first thing is we confirm it, whether there is a breach of the anatomical structure. The second thing is bronchoscopy helps in toileting. So you need to do the bronchial toileting at the same setting and send the sample for analysis, because you may pick up a offending organism in that. And third thing is bronchoscopy helps in determining the further plan. Let's say that I have a tracheo oesophageal fistula in the upper portion. Then probably my approach would be different from one I am looking at the level of the carina. Second, you need to measure the dimensions of the tracheo oesophageal fistula, so that you need to plan what is the appropriate sizing of the stent which you want to do it. So bronchoscopy helps in comprehensive assessment of a TEF. So all these parameters has to be looked into it, and then a further plan should be made.
Okay. So Deepak, my next question for you is that should it just be a bronchoscopy, or there should always be an endoscopy? Suppose there is some doubt on the bronchoscopy, would an endoscopy help in giving us better information, or it is at a standard procedure that even if you do a bronchoscopy and you've seen a fistula, would you still go ahead with an endoscopy?
If it's a case of esophageal malignancy, it would be mandatory to do both bronchoscopy and esophagoscopy both. And regarding the whether endoscopy or esophagoscopy is mandatory for confirmation of cough, no, it is not mandatory. But yes, for the therapeutic purpose, people are doing endoscopy and bronchoscopy simultaneously also, and they are doing a balloon dilatation so as to see whether there is any tracheal lumen compromise when we are using any therapeutic agent like if we are using the esophageal stent. It will cause the tracheal compromise that is to be seen only on the gastroscopy as well as bronchoscopy, which are done simultaneously.
Correct. Okay, great. So, since we have this group of panelists here, I just wanted to share one small case with you recently, because you all are also doing transplant at Hyderabad, Viswesvaran. There was a patient post-transplant about 3 months and kept having this mucus plug on the left side, just a sticky, very sticky mucus plug at the level of anastomosis, and we could not find any cause whatsoever. Multiple biofires, multiple infections were negative. It was just at one point at the suture side, we thought it looked like a pouch, but the esophagogram was negative. So the gastroenterologist did not want to go ahead with any further, intervention. We've still not figured out the cause of that. She underwent some, I think, 10 bronchoscopies over a period of 3 weeks, and then finally it has settled. So obviously it was not a TOF, because it's not a fistula, because it's not further come back. But just a question that came to my mind is, in such a case, I would have thought that there should have been an endoscopy performed as well, because sometimes if it's a very small fistula and if the esophagogram is done very quickly, you can miss that sometimes.
So generally, if you really want to know whether there is a tracheo oesophageal fistula, what you can do is just an endoscopy will not be sufficient. What you can do is you can instill a methylene blue.
Yes.
And then simultaneously you see whether that methylene blue is tracking into your airway lumen. Correct. So that will give a more confirmatory aspect to whether a TEF is really there or not.
Yes.
But in your case, since as you were briefing the case, ma'am, like a few things, because it was a transplant case, whenever you see a mucus plug or a whitish plug, always suspect a fungal infection.
Correct.
It can be a case of a tracheal aspergillosis, or even for that matter, just today only I posted one of the cases in our CCI group as well. It turned out to be it was exactly looking like a mucus plug, but it was a case of a mucormycosis.
Correct.
So any sort of a fungal etiology can mimic a mucus plug, especially. Correct. And when you have a background clinical history of a transplant, then we should always have it in the back of the mind. And a methylene blue installation would be the ideal one if you really want to know whether there's a breach in the anatomic communication or not.
Correct. So I just wanted to share this with you, because if it's a very small one, sometimes you could just miss it. And then filling methylene blue with a concurrent bronchoscopy. This patient, multiple times a plug, cultures, histopath, everything was negative. So one of those things where you don't know, but something seems to have worked, because now after a course of whatever medication, she's not had a recurrence so far. So another question now, Sukhram, thank you for being so patient. from a surgical viewpoint, any specific parameters that you would like the interventional pulmonologist to document on bronchoscopy that will help you, decide your surgical management?
Yeah, ma'am. If I look at, obviously, when we are talking with surgeon, it will be like a benign tracheostomy fistula. I'm not talking about the malignant one.
Yes.
So the first thing which, as a surgeon, I would like to have is what is the site of tracheostomy fistula? Like it is in the lower 1/3, middle 1/3, or upper 1/3. So likewise, what is the distance from the vocal cord and what is the distance from the carina? The second thing which I would like to have is the size, because all depend on what repair we are going to plan it. If it is the size defect is small, we might have planned the primary repair. If the size is defect is more, we might have to do the resection anastomosis. So the two things which require as a surgeon, it is before planning for surgery. But here I want to make it a point that when the bronchoscopy is being done, I would like to see the whole of trachea without tracheostomy. It should not be the with the tracheostomy the bronchoscopy is being done, because somewhere we want to see the whole health of the trachea. And then the second point is that exactly where is the cuff is placed, because most of these what we consider is the post intubation, because of the cuff pressure, these things are happening. So here I wanted to make a point that if there is these patients, obviously you don't consider them for stenting, because once you've done the stenting, they are out of the surgical preview, or maybe you're giving the unhealthy mucosa to the surgeon for the poor outcome. So if the cuff is like proximal to the defect, then I would consider them to considering the putting long flange tube, so that you will prevent the further aspiration. So because these patients, if they keep aspirating and swelling is there, they may land up in the aspiration pneumonia, or some sort of sepsis is always there. So we can prevent these further aspiration to giving the better result to the patient. And the last point is like that when we are doing bronchoscopy, obviously you have taken out the tracheostomy, the vocal cord should be looked for, consciously it should be looked for that. Because if vocal cord palsy is there, then there is a chances that we do repair, everything is being done, and at the end of the procedure, we realize that the patient is aspirating. So we have to put the tracheostomy again, and then 3 months later, you are doing some other procedure to settle the vocal cord palsy. So these three things, obviously, I would like to, and then further going down and looking for the bronchoesophageal fistula, which is like, common, not very common, but we have done 16, 17 cases of the bronchoesophageal fistula, where the fistula connection was between the bronchus and the esophagus. So I would like to have these three things in the mind, and it should be documented on the bronchoscopy report, that what was the size, where was the site, and the vocal cords are okay.
Correct. So your dimensions from, if it's close to the carina, your dimensions from carina to the fistula is also important, right, for you?
Yeah, ma'am.
Yes. So documenting the dimensions is also important. Because
yes, ma'am, it decides my approach. It decides my approach, whether I go from the thorax or whether I go from the cervical part. And the second thing is, if we are taking patient for the surgery, the bronchoscopy as well as the upper GI endoscopy is equally important, because sometimes fistula tract may not be the wish to wish. It may be diagonally, it may be some long tract may be there. So we may miss out the tract, because once we enter into the we have taken up for surgery, may not be able to decide on table. So it should be documented prior to the taking patient for surgery.
Good. So that's a very good point you have raised, Sukhram, about assessing the vocal cords as well. Because if there is a vocal cord involvement in a benign disease, if there is an infection and that is causing vocal cord paresis, basically you are wanting to do the surgery to remove that tracheostomy tube, right, which you have kept as an airway protection. You will not be able to do it if there is a vocal cord involvement. So going ahead, Aditya, when would you consider a stent in a patient of tracheoesophageal fistula, especially in a benign
yeah, so two circumstances is always when the stenting is being considered. One is bridging benign lesion towards surgical therapy, and then second for palliation of the malignant tracheoesophageal fistula. So whenever you are planning for a benign lesion, benign tracheoesophageal fistula, you just place it temporarily so that you improve the nutritional status, you improve the symptoms, and then post the patient for surgery.
Correct. So we don't want to have an infected patient ideally while we are sending the patient for surgery, because that can complicate matters. So you just put in a stent as a bridge, give appropriate antibiotics, try and get the lungs to clear out as much as possible. On the bronchoscopy, do a toileting as well. And yes, we have a question from Dr. Tridip Chatterjee that if prolonged intubation can be a cause of tracheoesophageal fistula, what do you do to prevent it? Do you do an early tracheostomy, or you do a frequent release of cuff pressures? So prolonged tracheostomy also can cause tracheoesophageal fistula. It's primarily to do with the cuff pressures. So as Sukhram has already mentioned, that you have to be careful about your cuff pressures, and there are centers which advocate intermittent release of deflation of the cuff. If you're sure that the patient is not having severe reflux, or if it's not going to aspirate, so based on your timing of the feeding and all that, you can do 5-minute release of the endotracheal cuff. Is that what everyone would recommend, or there are anything else that anybody would want to suggest? Okay, so going ahead, Viswesvaran, stent placement in malignant tracheoesophageal fistula, when would you do it? Or is that what you would only do?
Yeah. So whenever we speak about malignancy, the term is palliation. So here we are not looking for a definitive cure. So we are trying to improve the quality of life of patients. So definitely metallic stents have a much important role than the surgical in case of malignant tracheoesophageal fistula. So when do we really place it is, as we have seen that whenever there is a TEF which is compromising the quality of life of patients with recurrent pneumonias or other thing, then it becomes an indication. So we choose either a metallic Y stent or a metallic straight stent for the airways. And generally the stent is placed in such a way that there should be a 2 centimeter margin above and below the fistula, so that even if your stent migrates a little bit, you make sure that it covers the part of fistula. Second, covered metallic stents are generally preferred because here you want to prevent the reflux of the secretions. But the problem with the covered metallic stent is that there are higher chances of migration. So you need to, that's why we are giving the 2 centimeter margin above and below the site of fistula. Another important thing that is always a controversial thing is like whether there is a role of a double stenting, that is a combined tracheal stent with an esophageal stent, or you should go for a single stenting. So generally, when the size is more than 2 centimeters of the tracheoesophageal fistula, we prefer a dual stenting, because in case if it migrates, there will not be a false entry of the stent into the fistula. Because if the fistula is very big, there are chances your stent may also enter into a fistula. So to prevent that, better to do a double stenting if the fistula size is more than 2 centimeters. Or if there is an associated airway stenosis. For example, if a patient is having an airway stenosis with a fistula, then making sure that your airway stent is put first before the esophageal stent is put is also must. Because if you inadvertently put the esophageal stent, already your airway is compromised. When the stent expands further, it may further cause compromise of your airway. So these are the two indications where we will prefer a dual stent, and metallic stents are the treatment of choice when you are dealing with a malignant tracheoesophageal fistula.
Okay. So just to recapitulate, suppose you have a fistula which is just 1 centimeter above the carina, we would think of putting in a Y stent, right? Because you need a margin of, yeah. So just to clarify things for the audience. Great. So my next question, although you have partly answered, I'm sure Deepak can shed more light on it. What are the types of stenting? When you say single or dual, what are you talking about? Are you talking about 2 stents in the trachea, or you're talking about an esophageal and a tracheal stent together?
So,
and when would you decide, how would you decide, a single esophageal, single tracheal, or a dual stent?
Yeah, Dr. Viswesvaran has already given an indication that when you are putting a dual stent, that is one in esophagus and one in trachea. But frankly speaking, for me, it has been no. Though theoretically, we are reading that these are the procedure of choices. But in recently, what cases I have seen, as rightly mentioned, that it is made mostly for the palliative purpose, but the quality of life has deteriorated in patients in whom we have put 2 stents, because there was more of pressure necrosis, and both stents have caused the mediastinitis in these patients. Last 3 patients whom we did a dual stenting. Yes, theoretically, for the Tracheo Oesophageal fistulas which are having more than 2 centimeter diameter, you do 2 stenting, as rightly mentioned earlier, that to prevent the migration of single stent to the mediastinum. But still, I would prefer that a single stent would be a better modality of choice, and you can have a bypass for your feeding, like you can have a gastrostomy tube so as to prevent the aspiration of the contents, the gastric contents.
Okay. So back to you, Viswesvaran. If you are doing dual stenting, you've decided that you need a dual stent because either the fistula size is too large and you think that there could be a migration of a single stent into the fistula, or if it's a lower, tracheal fistula where there could be airway compromise if you only put in an esophageal stent, especially in case of malignancy where the malignancy itself is already causing some tracheal compromise. What stent would you place first? I mean, because this has to be a multidisciplinary approach with the gastroenterologist, and so do you place the tracheal one first? Do you place the esophageal ones first? What is your usual discussion with them?
So when it comes to, once you have made up your mind that you are going to put a dual stent, it is always airway stent first. Yes. So first thing is whether dual stent is required or not. But once we have that clarity that we are going for a dual stenting, then always put the airway stent first, because if you put a esophageal stent, the stent will expand because of the radial force. So in that process already, which your airway is narrowed, it may cause further narrowing. Then by the time, if you really want to put a tracheal stent, it will become an airway emergency. It has not happened to us, but I have heard from people where they have lost the patient, especially our gastro colleagues from other institutes. I have heard from them that when they try to put an esophageal stent, they had to declare a code blue and call the people and have to intubate, because they never anticipated that the esophageal stent will expand and will compromise your airway and you can lose the patient on tip. So if you are planning a dual stent, always airway stent comes first. So, and even for gastroenterologists, if they are planning an esophageal stent, as Dr. Deepak had already said, at least they should do a balloon dilation to see whether that expansion is capable of compromising your airway. Only then you should go ahead with an esophageal stent.
Correct. And what about when you're placing a dual stent? Is your length of the stent dependent upon the position of the esophageal stent? Because Sukhram has said that it typically need not be an edge-shaped lesion. It could be a diagonal, connecting. So how do you decide when you're doing a dual stent, how do you decide the length of your airway?
Yeah, so generally the upper end of the esophageal stent should be at a higher level than your tracheal stent. That is the dictum. So generally the length of the esophageal stent is chosen much larger than the stent of the tracheal stenting. So that your tracheal, so that there is enough support on either sides for the both for the airway and the esophagus. So this is what we follow. So whenever our gastro colleagues put an esophageal stent, after we put an airway stent, they make sure that the upper margin of the esophageal stent is above the upper margin of the tracheal stent.
Yeah. And I think just to make it clear, you would do both these procedures simultaneously, right? At the same sitting, so that in case there are
generally, it depends upon the criticality. So yes. In our setting, most of the time we do it as a staged procedure where the airway comes first. Once we stabilize the patient, and then we make sure that the patient is stable enough, then we'll go for an esophagus, because that is not an emergency. So generally we do it as a staged procedure where the first day we put a airway stent, then we stabilize the patient, then we hand it over to the gastro colleagues, they put it on the second day. But there are centers which can do it on both times. The advantage of doing it in the same setting is if there is some migration, you can intervene immediately. Yeah. If not, next day you should make sure that once the esophageal stent is put, you again have to keep your patient on follow, because there are instances when you have not chosen the appropriate size of a stent, initially you would have put the stent and come. Later, when the esophageal stent is put, there are chances that your airway stent may migrate also. So you should keep a follow-up of your patient even after the esophageal stenting also.
So would you routinely do a bronchoscopy after putting if you have put in a dual stent and you're doing it at a stage procedure, esophageal stent is a second stent, then would you routinely recommend that we should just do a quick routine check bronchoscopy before we discharge the patient?
So generally these stents are radio opaque and you can pretty much make up the positioning of the stent very clearly on a radiograph. So until and unless the patient is becoming symptomatic or we feel that there is a gross displacement of the stent in the radiography, we don't go for a immediate check bronchoscopy. We do the check bronchoscopies. Actually, there is no guideline on this, but it is our practice. We do a check bronchoscopy at the end of 1 month to see just for some granulation tissue or some plugging happening. And then once we know that the stent is being maintained well, then the next bronchoscopy, we do it at 3 months interval. But unfortunately, most of these patients do not survive beyond 6 months to 1 year. So beyond that, it might not be required also.
Correct. So theoretically, there is some the dilemma about that because it's a metallic stent, it could also further enlarge the and tear the margins of the fistula. So is there any role whatsoever of putting in a silicone stent in tracheoesophageal fistulas, Viswesvaran?
Yes, you can put, there are studies which have put even silicone stent for tracheoesophageal. So, but the point to be noted is when you put a silicone stent, you will never have the complete approximation of the stent to the airway wall. So your purpose may not be solved. Like you may get an airway lumen, but the spillover of the secretions may continue to happen because it is not exerting a radial force and it is not completely approximating with the wall. So we generally don't do it because many of these patients, as I said to you before, are done for palliative care. And so we are looking only at improving the quality of life, which should be very much attained with the metallic stent only. We have not tried it, but you can put it. But the problem is in such cases also, when you put a esophageal metallic stent, there are chances that it may push your silicone stent also forward, unlike your metallic stent.
Correct.
So one, the lack of complete approximation. Second, there is a theoretical possibility of a displacement of your tracheal silicone stent by the radial expansion of the esophageal stent is also there. So we generally avoid it.
Correct. So when you're doing a dual stenting, definitely you should, I don't think silicone stent will have higher chances of migration. So that would not be a good choice. In fact, metallic stents, tracheoesophageal fistulas are one of the few benign indications for putting in metallic stents as of now. So going forward, Deepak, some issues with stent placement. Everybody talks about putting in a stent, but of course, stents are fraught with their own issues. So what are the complications that you would need to look at regarding to the stents, and if there is anything that is specific for tracheoesophageal fistula? Deepak, you're on mute.
Yeah, I'm on mute. Yeah. So as mentioned in previously by Dr. Viswesvaran, that the stent migration is one of the complications which we see. Secondly, there are also chances that there is increase in the size of tracheoesophageal fistula because of the pressure necrosis, and also the migration, then stent fracture. These are the complications what we encountered during the once we are put in a stent for tracheoesophageal fistula.
Okay, so Dr. Sukhram, one question for you. What would be an ideal patient for surgical management? I mean, we have discussed that benign tracheoesophageal fistula stenting is just a bridge, or other interventions is just a bridge to surgical management. Any patients of malignant tracheoesophageal fistula that you would think about taking up for surgery? What, if at all, and what would be the indications?
Ma'am, usually in malignant cases, surgery should be avoided because it is fraught with the huge complications, and most of these patients are cachectic patients, and then these surgeries are not curative. They are just in palliative surgery, so high chances of the recurrence are there. The only place where surgeon has a role in malignant tracheoesophageal fistula is that the after therapy, the patient had curative result, and when there is a chances of tracheal fistula formation is there, or maybe sometimes the tracheal fistula formed with the conduit, not with the per primum, but the conduit had get fistulas to the trachea. So in those cases, surgeon may have role, but usually if these patients are post radiotherapy, so tissues are too fibrotic, and surgeon may be able to dissect or may be able to separate the fistula and able to put the some sort of muscle between the two, esophagus and trachea, but the high possibility of the recurrence is there. The only indication where I can see is that those patients who had the mostly disease-free or malignancy-free esophagus or trachea, where we can think about doing some sort of surgical procedure.
Okay. And as an extension of this question, what are the surgical techniques that, what are the options that you have, and how do you choose which one?
Yeah, ma'am. Before taking this question, I would like to take the whole management of the tracheal fistula. So that before taking any patient, obviously I am talking about the benign.
Yes.
So first thing, when we take a patient for this thing, there are certain principles which we follow is like these patients should not be having continuous soiling of the lung, or we should prevent the further aspiration. Now, answering to that, preventing further aspiration is not the stent. Mostly, if there is a rent, then the long flange tracheostomy tube should be considered, and this should be put the distal to the defect, because that will help more to the surgeon. Because if we put the stent, then the prognosis of the repair is poor. So we can help with the putting long flange tube, then toileting with the bronchoscopy. Further acid therapy, acid suppression should be done with the help of like putting patient on the proper position. And for feeding, gastrostomy or the NG should not be considered. It should be NJ, nasojejunal tube, or should be feeding jejunostomy. So the reflex should be lesser to the this thing, and patient should be placed in the proper position. Now, last but not least, these patients should not be on ventilator. They should be weaned. If they are on ventilator, because of the positive pressure, that these patients may not help their repair, and we will end up in the recurrence or dissection of the repair. Now coming to the what repair surgeon do usually. So we follow the, if in the upper 1/3 we approach the from cervical, and in the lower 1/3 or middle 1/3 we follow the thorax. Now primary principle of the surgical repair is the separation of the trachea and esophagus. Now these two should be separated. When there is a tract, we have to separate and do the primary repair of the trachea if rent is small, and primary repair of the esophagus if the rent is small, and putting muscle plate, so they should not go again adjoining and form the fistula again. So prevent fistula, we need to have some muscle plate between the trachea and esophagus. Now all these things are in the patient who has the small defect in trachea or esophagus. Those who have large tracheal defect, they may consider for the resection, primary resection and anastomosis of the trachea, and doing end-to-end anastomosis of the trachea, putting muscle plate and doing the esophageal repair per primum. Following which, these patients, like they are nutritionally depleted. So mostly what we do, we continue with the NJ feeding, and they keep them for the roughly for 1 or 2 weeks on NJ, and do the gastrographin test. If there is no leak, then we ask them to go for the normal feeding, oral feeding. Otherwise, we'll continue them to be on the nasojejunal feeding tube, so that nutritionally they build, so wound healing will help us. So mostly what we follow is the single stage approach. We don't follow the the separate or stage operation. The one the trachea was then repaired in the one stage, and the esophagus was repaired on the other stage. No, we don't follow. We visually follow the single stage, because it reduce the anesthesia time as well as the GA time, and obviously the trauma of double surgery is always way more than the single surgery.
Okay, so I have a question for Aditya. Do we routinely need to assess the efficacy of the stent once we have placed a stent? In the sense,
the assessment is necessary so that we know that we have successfully placed the stent. And there are several methods to assess the efficacy of the stent, like placing a nasogastric tube and instilling methylene blue. and then we can confirm it by a bronchoscopy that it is being passed over to there is any spillage over to the bronchus or not.
Okay. Do we routinely really need to do this, or is it only if we are still continuing to have infections, or if a patient's pneumonia is not, or his symptoms
if
are not?
We are in a doubt, if we are in a doubt that we have not been able to completely seal off the tracheoesophageal fistula, only then we need to do this.
Correct.
Otherwise, as Viswesvaran said, that we can assess this by radiology only that the stents are in place.
Correct. Okay. So another question for you, Aditya. Any role of any other endoscopic measures to seal off the tracheoesophageal fistula, like installation of glues?
So, ma'am, the installation of glues are done, but they have a very high failure rate, because if the size is less than 5 millimeter, only then we can think of putting a glue. But if it is more than 5 millimeter or 8 millimeter or more than that, glue is not going to be successful. So not much of cases we have seen also.
Okay. Deepak, any other devices that have been used or can be used for closure of the fistula, and when would they be considered?
So the other modalities, like as already mentioned by Dr. Aditya about glue, we can, for less than 5 mm, people have tried using APCs, and also the devices like your Amplatzer device, which are there, and also the clipping is also being done for patients who are having fistulas, but the data for all these things is very sparse. So whether they are useful, or what are the chances of, as earlier mentioned, that it is a palliative therapy. So what are its efficacy or safety measures is yet to be determined completely. Yes, there are many case reports in which they have used many different kind of devices, like they've used buttons as well for doing for closing the tracheoesophageal fistula.
Yeah. So usually that even the Amplatzer device, it works in smaller fistulas, right? And
Yeah.
I think the clipping, whatever, at least I was speaking to my colleagues in gastro, and this thing, they said that usually, often in fact, it causes further tear of the fistula. And so that is something that definitely now, I mean, now that we have other modalities, it's not something that they usually do, and they usually refer the patient to the intervention pulmonologist. So Viswesvaran, evac therapy, what do you, I mean, do you have any comments on that? What is it? When it could be used?
Personally, it is not, I have never tried, and it is not our domain also. But I had read this. So what they do is just, it is called as endoscopic vascular vacuum assisted closure. That is
yes.
So what they generally do is they put a endoscopy, that is basically your gastroenterology colleagues may use it. They put an endoscopy, they create a vacuum, and then they keep a nasopharyngeal tube with a sponge over it. So that the advantage is the sponge keeps up taking up the secretions, and it causes a granulation tissue formation. But what I have read about it is like it has only anecdotal case reports are there, and there is no claim that the evac helps in a much better outcome in comparison to others. And just for your previous question, these Amplatzer devices are associated, in fact, with a more risk of granulation tissue formation and your tracheal stenosis also. So generally, these are not used on a routine basis. So, and evac is definitely not our domain, and I have never used it, or I have never seen anybody using it. It's only with the theoretical knowledge which I have about.
So there are some anecdotal reports of tracheoesophageal fistula using Amplatzer device, but I think it's probably more published when we are looking at persistent air leaks or bronchopleural fistula. And but just there are some anecdotal case reports. So just wanted to know. I don't have any experience on using it, so. Good to know that, because when you meet people, they say, oh, we did this, we did that, but there has to be a standard of care, right? So which is what we want to make people aware of on this platform. So Dr. Sukhram, complication and recurrence rates post surgical management and how to manage it?
Ma'am, in our experience, we have done till now 43 cases, and the 2 of our post-operative patient has problem. So when I read the literature, the usually complications rates are less than 5% in experienced hand. Now, complication is like mostly happening in these patients that they are mostly debilitated, nutritionally debilitated patient, prolonged ventilation, not, unprepared patient, and then these patients are bound to happen, and mostly they may happen in the diabetic patient, which is a comorbidity presenting. So what we had was one patient who had the vocal cord palsy in the post-operative period when we were extubated, and the post-operative period when we asked him to swallow, and patient was not able to swallow, having cough. So one was the vocal cord palsy, second was wound infection, because mostly it is a swelling which is esophageal content or the gastric content which are into the trachea or into the wound. So the swelling is very highly, wound dissection is high chances. Then there is a chances of the whether tracheal repair is not holding, or esophageal repair is not holding, or recurrence is happening, or because of their continuous sepsis is there, or sometimes a few of patients which were not weaned properly or not off the oxygen and taken up for surgery, they continue to have respiratory failure. And most of these, like the wound dehiscence, are all these things can be managed with the antibiotics. And if vocal cord palsy is there, we can consider putting the tracheostomy tube, and then 3 months later we can consider doing some procedure to fix the vocal cord. If there is a recurrence, then we have to consider doing endoscopic therapies like putting the stent. If it is in early part, we may go in again and try to repair it. But if it is late part, mostly it is happening on the second week or third week because of the nutritionally debilitated patient or secondary to infection. These patients may be considered as putting the stent. Which side has leaked? If suppose esophageal side has leaked, then putting stent in the esophagus, or if tracheal side has leaked, or then we can considering the stent in the trachea. So mostly if there is a respiratory failure, then the patient should be built up and can be taken up for tracheostomy for certain duration. And once the patient is built up, able to walk around, then we can take out the tracheostomy roughly around 3 weeks later.
What is the latest possible recurrence rates or failure rates that have been reported in literature also after a surgical intervention for a benign tracheo oesophageal fistula? Because we had a patient at KEM hospital, because it's a public sector. All of us are in the private sector. So private sector and public sector patients behave quite differently. So, these patients are already debilitated, malnourished, follow-up is poor. There was a patient who had come with, bilaterally flooded lung, who had a recurrence of his, who had a failed second surgery for TO fistula after a post-intubation TO fistula. And he was just, he just came in severe sepsis, but this was, I think, after almost a couple of years of having the second surgery. So I was just wondering how late, and can it really happen so late, or was it just something that probably was missed and then it got picked up much later when the patient came to us?
And it's very late presentation. It's very rare, because what happens is like they are mostly into sepsis. If content are leaking from the gastric content to the trachea, so unlikely that they will survive for the years. So because it is, and they will be in the sepsis. So maybe it's another reason why they got it. It's something which has happened to them. Secondary infection was set into their primary repair, which is being done. Maybe sometimes there is a tuberculosis, because India is endemic of tuberculosis. These can eat up the primary, or maybe some lymph node which has eroded into the trachea or esophagus. Something that is very rare to have the primary problem coming years after the.
So some probably secondary infection, occult infection, which has become progressive also, which is contributing to the failure.
Yeah, probably took like.
Yes. So we have another question from Dr. Tridip. Have we seen endobronchial TB causing tracheoesophageal fistula in some cases? And then if yes, do we give AKT or we do intervention? So if I may answer this, it's usually not endobronchial TB, but we've seen lymph node TB, which is usually erodes especially when it is large lymph nodes, necrotic lymph nodes, caseating. It somehow caseates into the bronchial or the tracheal wall. I have not seen any endobronchial TB causing fistula. Any inputs from the panelists? No. Okay. All right.
Yes. Ma'am, we had a case who was because of lymph node erosion. The patient had tracheo oesophageal fistula and referred to us, but we asked them to go for ATT for at least 6 to 8 weeks, and then we thought of reconsidering. But when we did rebronchoscopy, the fistula got disappeared.
Correct. Okay. So I think we don't have any further questions. Any other inputs from the panelists? Anything else that I may not have covered in the questions that anybody wants to add, Viswesvaran? I can see a small smile on your face, so I'm wondering.
No, ma'am. I think almost everything is covered.
Yeah. So because this is not a very huge topic, we've kind of finished in an hour. So just to summarize, basically you have at least in the adult population, we have benign causes of tracheoesophageal fistula and we have malignant causes. Usually malignancy presenting as tracheoesophageal fistula is usually in the latter stages of malignancy. Life expectancy is poor. So therefore it is more about palliation, and therefore in those patients, you would consider putting in a stent to prevent recurrent soilage of the tracheobronchial tree and recurrent infections. Whether to do single stenting, double stenting will depend upon the size of the tracheoesophageal fistula. If you're putting in an airway stent, it will depend upon the location in the trachea, whether you're going to put in a straight stent or you're going to put in a Y stent. You need to have a 2 centimeter margin above and below the fistula to decrease the chance of migration and spillover. Therefore, your decision about a straight or a Y stent will depend upon its distance from the carina. Secondly, if you have a middle or lower airway esophageal malignancy, where there is a chance of tracheal or bronchial obstruction as well, along with the tracheoesophageal fistula or tracheobronchial fistula, you would consider putting in a dual stent and not just an esophageal stent. If there is a primary airway stenosis, yes, and there is a plan for putting in an esophageal stent, you would consider putting in a dual stent. If it is an upper esophageal problem which is causing a fistula, sometimes you can just get away with putting in only an airway stent. However, all this has to be in conjunction with your gastroenterologist. It is a multidisciplinary management. Tracheoesophageal fistula cannot be, the decision making should always be in tandem with your gastroenterologist. If it is a small fistula, less than 5 millimeter in size, and if suppose a patient is unwilling for a stent, or if you think there could be complications related to stent, you could try, especially in benign tracheoesophageal fistulas, you could try fibrin therapy, though they have a high chance of failure rates. And what kind of stent we have discussed, we will like to put a covered metallic stent. Prefer not to use an uncovered stent because that will not take care of the problem, which is basically leak of gastric contents, leak of food material and causing recurrent aspiration and recurrent pneumonia. And silicone stents, because they are dependent upon the radial force of the intactness of the tracheal wall, basically to prevent migration and to give approximation, they will not always serve the purpose. So I think I've kind of summarized everything that we have discussed. There is a unique role of the surgeon, and in benign tracheoesophageal fistulas, we should always consider any intervention as a bridge to surgery, and whatever decision we are doing in terms of intervention should again be in conjunction with their opinion. Because as Sukhram has said, that we would like to put in a stent. However, as he had said, is that sometimes if there is a tracheostomy already, you may as well, instead of putting in an airway stent, you think about putting in a longer flange tube, which will kind of act like a stent, and it will help them in post-op, because the stent sometimes, if it's causing granulation tissue, if it is causing mucosal inflammation, that will actually complicate their case and their post-operative care and post-operative, chance of, it will change their post-operative chance of recurrence and having clean margins. So I think that's my bit to summarize whatever we have discussed today. I thank CCI for having this very interesting webinar, because this is not a topic which is discussed as often, because it is not something that we see routinely. However, I know it is a diagnostic and a management quandrum from most of the people. Please remember, multidisciplinary discussion is always important to manage this. I thank Dr. Deepak Muthreja, Dr. Aditya Chawla, Dr. Viswesvaran and Dr. Sukhram for their great inputs and making this webinar absolutely stupendous. Thank you.
Thank you, ma'am. Thank you very much.
Thank you.